Well, okay. Thank you very much, Mary, and good afternoon, everyone. I'm Sam Pullen. I'm a general and child psychiatrist in terms of my own clinical background. I presently serve as the Chief Medical Officer for the Idaho Behavioral Health Plan with Magellan and have the privilege of working with Jennifer Bly and Tabatha Haywood. And I also want to acknowledge our colleague, Jess Wojcik. She is our manager for the peer support services that we offer here in Idaho. She was not able to join us this afternoon for this presentation, but she contributed significantly to the slides and the content of our presentation today. And so we were grateful for her contributions as well. As you can probably imagine in the slide, the title of our presentation that you see here on the slide, especially the village reference, this presentation is geared towards a broad audience. And so it's certainly geared towards caregivers. It's geared towards persons who may have been patients who they themselves may have been psychiatrically hospitalized or treated for a mental health condition. And it's also geared to the clinicians and others within the ecosystem of mental health care that may be involved in their care in some way. And so as a result, this presentation, while it does have some data and statistics and other kinds of more clinical kinds of terminology that we'll make sure to discuss and define where needed, it really is geared towards a broad and heterogeneous audience. I want to begin by acknowledging Empower Idaho and our colleagues at Janus just for inviting us to speak with all of you today and to present here today. We greatly value their partnership in the work that we do supporting mental health care here in the state of Idaho. Neither I nor any of my colleagues have any disclosures of any kind to make, and so this is just our requisite disclosure slide here. Our objectives are to discuss strategies to improve resiliency and advocacy for caretakers of adults with serious and persistent mental illness. We want to discuss strategies to connect with the caretaking network, and we want to discuss resources and services that are available through Magellan here in the community. So I'll begin our presentation by just giving a little bit of history and overview of psychiatric care here in the United States to really describe where we came from in terms of how mental health care was practiced and delivered in the United States to today, and how we really got to the systems of care that clinicians, that patients, that caregivers have to navigate today. And so I think a little bit of historical context is important. And that's illustrated through several trends that you see here. The first trend really highlights this pivot or shift from predominantly inpatient psychiatric care that occurred in large institutions, large public hospitals. And really, that was where much of the care, particularly for adults with serious and persistent mental illness, occurred. So you saw by the mid-1950s, 560,000 inpatients in public psychiatric hospitals throughout the United States. By 1994, that number had been reduced to 72,000 inpatients in public psychiatric hospitals, even accounting for an almost 60% increase in the US population. And then the second set of statistics also illustrate this point about the reduction of inpatient beds per capita. So in the 1970s, we had around 300,000 inpatient beds per capita. And by 2014, that number was almost cut in half. This trend in terms of shifting from these large public or state psychiatric facilities to more of the community really was enabled by several key developments. One was the introduction of more effective medications, particularly the antipsychotic class of medications. So these are traditionally known as our first or second generation antipsychotic medications. And these were instrumental in the care of adults suffering from illnesses such as schizophrenia, bipolar disorder, major depressive disorder with psychotic features, and so on and so forth. These were the kinds of illnesses that traditionally patients were psychiatrically hospitalized for. And with the advent of these class of medications, really did allow them to transition out of the hospital and into the community as their symptoms improved. The second piece or component that contributed to these trends was really related to policy. And this is exemplified by the Community Mental Health Act that was put into place back in 1963 that really created policies around encouraging mental health care into the community and transitioning away from psychiatric care in the hospitals. Unfortunately, the budgets, the finances needed to support this transition from hospital to community did not necessarily coincide or follow suit. And so this did contribute to really an uneven transition from hospitals to communities, and where community services may not have been supported or received the financial dollars to support the kind of robust care and treatment. And you see that in our fragmentation of our mental health system today. The second trend that I'll call out really started after the conclusion of World War II, where we really saw this huge expansion in outpatient mental health services. Particularly, we saw this massive expansion and rise in therapy-based services to really complement this movement from hospitals into the community. The third trend was noted with this rise in healthcare expenditures. Now the involvement of insurance companies and managed care organizations, and that came with a lot of positive benefits, but also came with some things that created more bureaucracy, I guess, if you will, and more hurdles and areas to navigate. We also saw the additional policy changes, such as the Mental Health Parity and Addiction Equity Act in 2008, which really said that mental health conditions needed to be treated the same as physical health conditions. And we saw the Affordable Care Act, which is sometimes referred to in the lay press as Obamacare, which really expanded coverage for those who lacked insurance coverage. So this was really the act that triggered this expansion in a number of states, now nearly every state with Medicaid services, and that includes here in Idaho as well. And then the fourth trend I'll briefly touch on is the medical, really this advent of the medical model of care, not only in traditionally physical health conditions or surgical cases, but now inclusive of mental health conditions. And so really thinking about mental health conditions less from kind of some of the traditional kind of psychoanalytic models that were supported by Sigmund Freud and his contemporaries, to more of thinking about some of the biological basis for mental health care and mental health conditions, and thinking about how those conditions were caused or at least contributed to by biological or neurobiological processes in the brain and the body. And then in the 1990s, the recovery models of care, which really enabled more of a holistic approach to mental health care with the involvement of peer support, case management, care coordination services. And so these are important trends as we kind of think about the system of care from a historical lens to where we're at today. There's really two ways, I think, that you can think about the delivery of mental health care and services. And so one way that especially clinicians traditionally think about mental health care is really through the language of statistics and kind of more population-based kinds of metrics and data. We think about this in terms of diagnostic nomenclature and so forth. And this is a really important way to think about mental health care, especially when we're trying to understand the magnitude of the problem. And so this is just recent data and statistics that are put out by NAMI in the local Idaho chapter. And you can see just the critical importance of mental health care and delivery, effective delivery of mental health care here in our state. But data and statistics and these diagnostic categories also don't capture the whole picture. And so when we think about the other way that I like to think about and that my colleagues like to think about the delivery of mental health care, it's actually captured in patient stories. And so these are brief clips from qualitative research studies of caregivers of persons with mental health conditions, and just really kind of thinking about it from their perspective. And so some of this can be lost if we reduce mental health services to kind of this data and statistics. And we really sometimes can lose sight of individuals and the stories that they have, because everyone's story is different. And so when we think about how do we support caregivers and how do we support patients, our members with mental health services, it's really important to think about their stories and their individual experiences. And so this is another study that really looked at some of the caregiver stories and the themes that they shared. So these are direct quotes taken from caregivers of adults with mental health conditions from this study. So one theme was around dealing with unexpected or even shocking news and not really fully understanding what was happening to their loved one or what was going on. And so that's an important starting place when we are rushing to provide services and care, and we're trying to connect patients with all of these different things. Sometimes it's important to stop and really appreciate how devastating some of this news can be, and there may not be even good mental health literacy, so not even understanding some of the terminology or what all this actually means for patients and for the caregivers that are taking care of them. Other themes that were captured in this study were the ones that we're hoping to speak to in today's presentation, right? Feeling lost in fragmented healthcare systems. And how do people even try to navigate something as complex as our healthcare delivery system here in the United States? Dealing with an uncertain future. And this is a big theme with my patients and their caregivers, and just the unpredictable and chronic nature of many mental health conditions, particularly after they've been hospitalized. What happens next? Will they be hospitalized again? Will these symptoms ever go away? Just to give a few examples of the kinds of questions that are illustrative of this particular theme. And then the last thing that I'll mention that was captured in this study was wanting to be an active participant in care, but not necessarily knowing how, or even feeling like they were not really treated as an important part of the patient's care. And so that was a frustration that was expressed by a particular caregiver in the study. There were many more themes. I didn't have room to put them all on this slide, but the general trend is towards just kind of the dealing with the emotional devastation of mental health conditions and how that impacts their loved one, uncertainty, and wanting to be a part of their care, but not knowing how. So to summarize, when we think about, patients, and this is oftentimes, if you're a clinician on this webinar, this is oftentimes something that you may hear from some of your patients or your clients, and some of their frustrations with trying to navigate this mental health system of care. And so you can see some of the themes here. Including things like prolonged wait times, not being able to get in to see anyone, having to go to the emergency department and being overcrowded, and you have staff that may not be well trained to really work with that person, particularly in a trauma-informed way, and just all of the other areas that they have to navigate. But I think it's critical that we not lose sight of the impact to caregivers of adults with mental health conditions. And this is just a figure that was taken from one of the studies that you'll see in the reference section at the end. But if we even think about the impact to caregivers from a trauma-informed or trauma perspective, we actually see similar themes as we do with their loved ones who are trying to navigate this complex, fragmented, and often frustrating system. And this is the system that we are entering into, and that we certainly are really committed to trying to help members and their loved ones navigate to the best of their ability. Why? Why is it so important to do? That in addition to just being the right thing to do, right, the human thing to do, we actually have good data that this is important from a recovery and relapse prevention perspective. And so if we think about our patients, our clients who've been psychiatrically hospitalized, we have actually really good data to support the importance of including family and loved ones, and including making family psychoeducation an important part of their overall treatment. And in this particular systematic review, this was a meta-analysis, so a study that looked at a whole bunch of other studies. This was the key finding that the more that family interventions and family psychoeducation, caregiver engagement, and also cognitive behavioral therapy, these were the key factors above all the other treatment interventions that were looked at that really helped to prevent patients from having to go back to the hospital. And so I think the importance here can't be underestimated. And then, so what do we do with that? And how do we support caregivers yes, they're trying to grapple with all of this, this information that they're getting overwhelmed by, because we know that we need them if we're going to put effective treatment plans together for patients that we're caring for. And so really what we want to spend the rest of our presentation talking about, and then we're going to open it up for a Q&A for the second half of today's talk, is really thinking about caregivers as critical members of the treatment team. We often think about caregivers if we're taking care of, say, a child or an adolescent, because we have to engage their parents or their legal guardians. But it is equally important to think about our adult caregivers as critical team members. And whenever possible, and sometimes it's not, but whenever possible, really actively seeking their engagement in the patient's treatment plan. We want to make sure that we're also spending time addressing caregivers' experiences and perceptions, because if they feel lost, or they have become jaded, or have other kinds of negative experiences or feelings about the mental health system of care, that's going to negatively impact not only them, but also it's going to impact their loved one who was receiving, who you're trying to care for. Lastly, we want to look for opportunities to educate and empower caregivers to be an active participant in managing this system of care. And this system of care in this slide looks like a very nice circle. It's all the different components are put together nicely. And what it really looks like is it looks like this big giant spider web. And so, we at Magellan, as the managed care organization, you if you're a clinician, really have an important role to help patients and caregivers navigate that. And so I'm going to turn it over to Jen for this slide here.
Thanks, Dr. Pullen. Good afternoon, everyone. My name is Jennifer Bly, and I come with experience as a registered nurse. And part of that role really focused on educating not only the patient, but educating the caregiver as well, as an individual was transitioning from an inpatient setting to the next level of care. So what I'm going to talk about is understanding the discharge plan, and then offering to help with medications, why that's important, offering to help with any follow-up appointments and why that's important, and then supporting the self-care of the individual. So going back to the discharge plan. So during all inpatient hospitalizations, part of the process should be the development of a discharge plan. The discharge planning process begins right at the time of admission. Many assessments are completed that help inform that discharge plan, and then the course of treatment all the way to the final days of inpatient service. That discharge plan will indicate three things: where the individual will be discharged to. This could be to the same setting where they originally came from. It could be the home, it could be another setting, or it could be to a different level of care, potentially. The goal really is to get, if possible, the individual to discharge back to the same setting where they came from prior to the inpatient admission. The second piece of the discharge plan is the types of care the individual will need after discharge. This could be outpatient therapy. This could be a different type of care. This could be in-home care. The discharge plan should indicate that. And then the final piece is who will provide that care. It could be a caregiver, right? The focus of this presentation here. Or it could be somebody else, because potentially the caregiver is unable to provide that level of support. So those are really the key pieces of that discharge plan. It's really important that not only the patient is involved in that discharge planning process and development, but also anybody that could potentially be involved and support that individual with care after discharge. Having all of that information and participating in it together will then help with determining any unmet needs or any gaps. So for example, if there's a new diagnosis that the patient is not familiar with, or that a caregiver is not familiar with, that's a great opportunity to ask the care team at the inpatient facility all kinds of questions about that diagnosis. What does that diagnosis mean? What are some signs and symptoms of that diagnosis? So that's a great opportunity to kind of start that conversation there. And then after discharge, it will continue to be important to follow up and educate on that diagnosis if it is new. So, for example, accessing trusted resources to learn more about it. That could be accessing something like the Mayo Clinic website or your health insurance website. Any trusted resource that can provide those educational resources to just give yourself the tools, or the caregiver the tools that will help them better prepare to support that individual with that specific diagnosis. And then the other thing that's part of the discharge plan that's very important is talking about and developing a crisis plan. So, with the crisis plan, this is a key component that can help in the outpatient setting, that the individual can identify the services and supports, the crisis services and supports that are available to them in their area, wherever they live. These crisis services include 988. That's available to anybody in the country. We hear about 988 quite a lot. It is out there and available for anybody. The second opportunity is a crisis center. So in the state of Idaho specifically, we have several crisis centers throughout the state, and these are available for anybody that's experiencing a situation where they just need additional support and service. The individual can go to the crisis center and stay for up to 23 hours and access some of those supports. So it's really important to help as a caregiver to help know what those resources are and where they are. So that way you can document those and start developing the plan. The crisis plan can also include trusted support individuals such as friends, family, a school teacher, a therapist. Write those down and have those phone numbers available also. So that way, and it's a shared agreement, it's a shared plan that should the individual start feeling like they're approaching a crisis, you as the caregiver and then the individual that you're supporting can go to that plan and start working through it together. This will help with emergent situations, as well as potentially avoid an inpatient hospitalization. So the final part of the discharge plan will include any medications. So potentially during the inpatient hospitalization, there could have been changes to a medication if the individual was on it. During the course of the stay, they hopefully have talked about, and if not, should talk about any medications that the individual was on prior to admission. These include vitamins, supplements, or any other over-the-counter medications. It's important to know the full medication story and then make sure to ask the question of the provider at discharge if they should continue or stop any of those medications. Additionally, it's important to learn and understand any new medications. What are they? When should they be taken? How often? And what are the potential side effects to be aware of and to know and to look for? So it's really important to have those conversations with the providers just to better prepare for that discharge. And it's important for medication compliance purposes. The more you understand about the medication purpose and the side effects, the better the compliance will be potentially. And then the final piece of that is the individual able to access the medication? Do they know how to fill the prescription? Are they aware of any costs associated with it? Will insurance pay for that? Are there any resources available to help support the payment of that prescription medication? If we can ensure all of those questions are answered prior to discharge, then it will just help keep the individual compliant with those medications to help ensure that they're consistent and stable post that discharge from the inpatient setting. And then offering to help with any follow-up appointments. So during the hospitalization, prior to discharge, an outpatient appointment for follow-up should be made at that time. And if it is not, I would ask and see if the appointment could be made prior to that discharge. The inpatient facility can help to identify any providers in your area, can work with your insurance if that's applicable to help identify in-network providers, and then understand when the follow-up appointment is and how will the individual get to that follow-up appointment. Is transportation a barrier for this appointment? If it is, potentially, there's always virtual options for that follow-up appointment as well. So exploring those opportunities to see if there could be a better option. The importance of the follow-up appointment is to continue the care that has been received for stabilization in that inpatient setting, to ensure that they have that consistent care going forward. Similar to consistent follow-up with a primary care provider on the physical health space, it's just as important that we have follow-up care and regular visits with our primary behavioral health therapist or provider as well. And then the final thing that I'd like to just mention is supporting the self-care for the individual. So ensuring that they're not wholly focused so much on, their illness or any other stressors, but making sure that they're going for regular walks if that's what they enjoy. We see a lot in the chat today about going outside, walking our dog. Support that individual also in ensuring that they're doing the things that they enjoy also. If they have pets, if they have other family members, if they have friends, try to support them in those areas as well, just to ensure that we're wrapping that individual around with all of the care and support that we possibly could. And with that, I'm going to pass it off to Tabatha for the next topic.
Hi, good afternoon, everyone. My name is Tabatha Haywood. I'm happy to be with you here today. I get to review some helpful reminders, encouragements, and some resources. But I'll start off with saying self-care is not selfish. We need to give ourselves credit. Caregiving is one of the toughest jobs there is. So we want to remind you all to be gentle with yourselves. It's okay to experience, some possibly heavy or negative emotions. But as we allow those emotions for us to feel those emotions, it's a part of our caregiver experience. And so when you allow yourself to notice those without feeling guilty or judging them as either good or bad, you get to dial down that stress and feel more in control. And when we're feeling less stressed, we're better able to thoughtfully choose how we react and communicate to our loved ones. We want to recognize the signs of caregiver burnout. Are you withdrawing from maybe your own activities? Are you seeing different strained relationships, changes in your sleeping patterns? Are you noticing like your whole identity is being wrapped up in only as a caretaker? Because burnout can lead to our own mental health challenges and potentially chronic and physical health issues. Prioritize self-care, making sure that you're not missing your appointments and reaching out to all of the resources that you have. So if you have an employer assistance program, reaching out to those free or low-cost counseling opportunities for you to take care and prioritize yourself. I don't know if you all are like me, but I love a good task list. So, create a task list, write things down that needs to get handled on a daily basis so you don't feel overwhelmed. This task list can serve as a foundation for organizing responsibilities and also identifying areas where help might be needed. And the biggest part is, asking for help. Sometimes if you're having a call, that phone might feel like 1,000 pounds to try to reach out and ask for help. But asking for help is so important. And delegating caregivers' tasks doesn't diminish your role as a caregiver yourself. It ensures that essential responsibilities are being met while you're doing your best to also avoid the burnout. Next slide. We want to encourage self-determination. Self-determination promotes recovery. So when an individual who's experiencing mental health challenges is empowered to participate in the recovery, their mental health is more likely to improve. The more involvement an individual has in their treatment, the more likely that their treatment will be effective. Build time in for yourself. I know this is easier said than done, but when you're a caregiver, it can be incredibly challenging to find or carve out time specifically for yourself, not in your role as a caregiver. But learning to make time for yourself without feeling guilty or neglecting, feeling like you're neglecting other duties is super critical. Any time that you can take, whether it's 5 minutes a day, 10 minutes, making sure that it's something meaningful that you like to do. If you enjoy time with your friends, try to schedule a monthly coffee visit so that you're just, connecting with people that are supportive of you. This makes it easier to also plan around the other activities that you might have going on. So plan time for yourself. It's so important. And then the other piece to also talk about is, giving yourself permission to grieve. Caretaking is one of life's most demanding experiences and likely takes up a large amount of time. Allow yourself to recognize how your life has shifted, maybe, and give yourself room to feel, that sadness or frustration or anger or anything else that comes up that may arise. The other is connecting to other caregivers, so important. Talking about your experiences can help. The idea that you can or should be able to solve things by yourself only creates loneliness and potential isolation. We do have some wonderful resources that we'll share on the next couple of slides. Notice the positives. It's so easy to get caught up in the negatives of, situations, but noticing the positives when you take a moment out of your day, your experiences of that day become a little bit lighter. So, I love the sunshine. I cannot wait for the sun to come. So just being thankful that it's a beautiful day outside changes my perspective of things. And all those little things start really counting, and it can start to change your experience of life. As I end this piece of the presentation, I also just want to stress the importance of giving yourself credit and even more grace. We're all human. We're all trying to support one another. And so sometimes we're hardest on ourselves. And so give yourself more grace. Next slide. Here we have some wonderful resources that, again, you'll get a copy of these with the PowerPoint. So the NAMI family member and caregiver resources. SAMHSA online has wonderful family resources. The Circle of Care Guidebook for Mental Health Caregivers, Mental Health America resource, the Family Caregiver Alliance resource, the NAMI Idaho Support Group Calendar for individuals and families. If you go to the NAMI of Idaho, the search can be narrowed to the family support groups or the family to family courses. Those are wonderful and amazing. The Caregiver Action Network offers a Facebook group for family caregivers. So this might be something that would be beneficial for y'all. National Family Support Technical Assistance Center. So they have groups the first Thursday of the month at 11:30 Mountain Time. And there's also webinars the third Wednesday of the month at 12 Mountain Time. And then the Depression and Bipolar Support Alliance, so DBSA, a resource for parents and caregivers. They, if you go, they offer family and friends support groups through the link below, which is the Hey Peers support group. If you go to the DBSA website and enter family in the search bar, it'll pop up in the Hey Peers support group. Hopefully those are some good resources for y'all, and I'll turn it back over to Dr. Pullen.
All right, thanks, Jen, and thanks, Tabatha. And so these are just some of the references for some of the earlier data and statistics, as well as some of the studies that I had referenced in some of the earlier slides. So we've got about, I think, 15 minutes left in today's webinar. And what we'd like to spend the remaining time doing is just answering questions that you may have about anything that we've talked about today, or if this is has triggered some other questions, we're happy to field that as well. And so I'm not sure how we want to, we should have probably talked about this ahead of time, but how we want to kind of field the questions, but certainly put those in the chat. And then we'll try to get to as many as we can. We do recognize that we may not get to all of the questions today. And so we do, we're happy to answer questions. If you want to send those to Mary, she can certainly get those questions to us, and we'd be happy to field those as well. So maybe I'll start by just kind of seeing what we've got here in the chat.
Yeah, Dr. Pullen, I can just kind of announce a couple questions that we've received so far.
Fabulous.
And yeah, so we did receive a few. I'm going to address a few of them right now. So we did just get a question in. Is the Benchmark Mobile Crisis Unit a part of Magellan? And yes, it is. So I can speak to this one. I'll just take it. As part of our current contract with the Idaho Department of Health and Welfare, we do administer crisis services, which includes the mobile crisis units. So we have agreements with Benchmark and Community Bridges to cover mobile crisis service across the entire state of Idaho. We have, I believe, 4 teams, 4 mobile crisis teams across the state. And so anybody in the state has access to those mobile crisis services. So that was that question. And then we received another question that asks, how are healthcare systems and insurance companies supporting the experiences of caregivers? This is often unrecognized, uncompensated, and complex.
Yeah, that's a great question. And I think that was some of the driver for why we were excited to do this presentation, because we also see that as a gap. And I think the honest answer is that health systems and payers, managed care organizations, just as a general description, could do more to do exactly what the person, what you're getting at, the person who had asked the question, in terms of supporting caregivers. And so I think that there are opportunities. One, I think first to recognize the importance that caregivers have in supporting patients, members. I use those terms interchangeably, for their loved ones who are being treated for some kind of mental health condition or substance use condition. So I think it starts there, is that recognition of the importance of caregivers, the importance of supporting the caregivers themselves, as you heard us talk about today, and then helping caregivers to navigate this system. And so that's certainly something that we at Magellan are committed to doing, and really helping to do that for folks here in Idaho who utilize Medicaid services. It's something that should be asked, I think, of other payers as well, that they should play an active role in helping to support caregivers and their members in this mental health journey. And it really is actually something where we do have opportunity to partner together. I think that really gives the best outcome, but I do think that there's more work to be done in that space.
And if I could add a little onto that, I'm a big proponent of care coordination services to support both the individual as well as the caregiver. So oftentimes an insurance company will offer this as a service. They'll either call it case management or care coordination. Magellan offers this service. It is included in the benefit program for Medicaid recipients. And the care coordination can help support the individual with accessing services, identifying those services, so on and so forth. But it can also help support the caregiver in terms of, while they may have a different insurance provider or different benefits, at least having the opportunity to share ideas about potential services and help educate around those types of areas, that then it gives them the tools to go to their provider or their insurance company and ask those questions of them. And so really kind of advocating, like I said, for the care coordination services to help offer that support.
Do we have any other questions? Let's see here.
I think we got a follow-up question to the mobile crisis asking, will Magellan be offering community training or training to our police, especially in rural locations? Shoshone County could use the resources. So we can absolutely take that one back to our director of our crisis services and see if he can schedule something. I know that he's an advocate of getting the word out around those crisis services. So we can put a bug in his ear around that.
Yeah, absolutely. Let's see here. And then there's a comment in here, program manager with Idaho Caregiver Alliance. This is something we talk about commonly. We'd love to connect on this. So Sheila, yes, we would be happy to connect with you on this topic, and we share your enthusiasm and passion about this kind of work. So yeah, we would be happy to do that. And I've got your email address, so we'll make sure to reach out to you.
And I think we did have another question about some of the support meetings. If you could click back a slide, Dr. Pullen, to
Yes, I can.
when the peer support, I think that's what the question was getting to. Yeah, there you go. So the question was, third Wednesday of the month meeting was located where? So there you go. I don't know that we have, I don't know if it's virtual or if it's
Yeah.
a,
It's a webinar. Yeah.
Perfect.
Yep.
And those were the only questions that I've seen come in so far.
And a concerned citizen call 988 to help someone who may be, I'm guessing, who may be experiencing a mental health crisis. Yeah. Yes, Nicole, it doesn't have to be the person themselves experiencing, some kind of mental health crisis. If you're a family member, or you're just even a good Samaritan, and you're concerned about an individual who may be in a mental health crisis, you can absolutely call 988 and get guidance to help support that person in whatever ways appropriate. And they can then also, dispatch a mobile response team to help support that person as well, if that's appropriate. Great question. Oh.
I was just checking. So we did have a question that came in through the Word form. So the question is, a friend is hesitant to start therapy because they do not want to be forced to go to the hospital if they talk about suicidal thoughts. They have been voluntarily hospitalized in the past for suicidal ideation. How would you empower them to access mental health care on their terms so that they feel more comfortable to share their true experiences with their therapists? I thought that was a really good question. One, I would start by validating their experiences, right? It's normal and it's common to feel like, if I share this, is this going to happen? Especially if we don't know if that voluntary hospitalization was, a positive experience or not. But then encourage them. I would encourage them that, you know, when they're looking for a therapist, like they can ask their therapist, what is your approach? How do you normally handle discussions about suicide? If I have suicidal thoughts, what is your approach? And it's almost kind of like interviewing the therapist to make sure it's going to be a right fit too. I know Jen talked about crisis planning and having a safety plan in place. Does your therapist, you know, is that one of their approaches to help empower by building that safety plan when you do have those suicidal thoughts, so that you have a plan in place other than hospitalization? Because part of therapy, we definitely want to be able to provide that supportive, encouraging, and welcoming environment so that they can share their true experiences with their therapist. Jen, Doctor, do you have any additional?
Tabatha, that was such a great answer. I don't know that I would add anything to that. We have a question here regarding it's a coding question. Can the counseling family code for billing be used for caregiver family members to have a person talk with, even if the caregiver has their own insurance with a huge deductible? It's a great question, Terry Ann, and it's a question I would probably want to take back to my to our coding team to make sure that we give you an accurate answer to that. So we're happy to take that one back.
I hate to cut this short, but we're pretty close to the end of the hour. Thank you so much, Dr. Pullen, Jennifer, and Tabatha. What an informative presentation. I'm going to send an email out in an hour or so with the survey link and the links from the sessions. And and Eden will put the survey link in the chat. There it is. It's up there. Please click on it and fill it out. It'll only take a minute or two, and we greatly appreciate it. On that last question from Terry Ann, if you give us, well, I have a copy of it with me, and I'll get an answer and send it out to the group from Dr. Pullen and his experts that he will be conferring with. So if you have any questions, send them to the Empower Idaho email. Eden, if you'd put that in the chat, that would be great. And once again, the slides and recording will be on the website in a few days. And the slides do have clickable links in there for all of those resources, which is very nice. Otherwise, thank you everyone for attending. We really appreciate our presenters. Thank you, Lavona, for your interpretation. And thank all of you for showing up. We appreciate it.
Thank you.
Have
Thank
a
you.
great
Thank you.
day.
Thank you.